in the first 3 webinars, we explained about the need and the importance of clinical case reporting in homeopathy. Robbert van Haselen spoke about home case care guidelines, which are guidelines on how to organize a proper homeopathic case report. Dr. Chetna Lamba has done extensive research on the field of case reporting in homeopathy, and specifically in the evaluation of criteria for assessing causal attribution of clinical outcome to homeopathic intervention. That is criteria to assess whether the homeopathic remedy or remedies created a curative action or an action towards the right direction of cure. And these criteria are called the modified Naranjo criteria for homeopathy. During the previous webinars, we conducted a poll in which we applied these criteria in webinar 3 on Dr. Maria Peppa's case. And due to different answers from the attendees in some domains of the poll, this case will be briefly presented again today for discussion about the item 6 of the criteria, which refers to the direction of cure. Maria will focus on the chronology of appearance of the symptoms during the acute and the disappearance of the symptoms after the administration of the remedy. Okay. Robbert van Haselen, Chetna Lamba, Professor Theodore Lilas are in the panelists today. Our host is again Andrea Tsokanas. Our guests are Dr. Maria Peppa and Tamara Romaine. Now I want to ask Dr. Maria Peppa to present her case. And after this, we will revisit hearings law to see also in relation with the item 6 of the MONARCH criteria, if these appear in your case, and have a little discussion on this. So, dear Maria, unmute your microphone.
Hello to everybody. I'm going to make share screen. This is a case that can show us very well the rules that Demosthenes Hering's rules. It's about a 40 years old woman from Bulgaria that is working in England as a doctor, that she is COVID-19 detected. See, we can see that I'm going to say more about the timeline, because I know that Lefteris Tapakis in the last webinar, he talked about my case. She started at 11th of April feeling fatigue, tired, and a little bit stuffed nose and sore throat. After that, but she was continuing going to work normally. On 13th of April, she became worse. She had headache, watery eyes, anorexia, chills. The fatigue became worse, and she got nausea. And about 18th of April, she had temperature, and she decided to go and make a test and to stay at home. I found out about her condition on 20th of April, and we have talked through internet, and she explained me what are her symptoms. I told her what she has to take, but it was a little bit difficult to find homeopathic remedies, and she had to take them through internet. At last, at 24th of April, she received the medications. By that time, she was worse. She was feeling she was sleepy all the day. She had temperature, the temperature was not very high, it was about 33, 38. She had pain muscles, in the muscles. She could not eat, and she could not stand up from the bed. At last, at 24th at 9 o'clock at the evening, she took 1 dose of pyrogenium 1M. After that, she took it at 11 o'clock, and in 3:30 in the morning, she woke up and she had nothing else, only fatigue. The temperature was fall down, she didn't have nausea, she had nothing else except from fatigue. And after that, the fatigue was going on. I consulted her to take muriatic acid. Again, she could not find it, and we were waiting till the 2nd of May, but the fatigue was not going away. That she took 1 dose of muriatic acid, and since then she's feeling healthy and she's going to work. The interesting thing is that everything has started with fatigue, and it finished with fatigue. And I think it's a good case to talk about Hering's rules. What else you want to say?
What is interesting, I think, Maria, in this case, is that the patient was desperate. The symptoms were continuing, and she was not seeing improvement day by day, and she only saw improvement after taking the remedy. So it is good to also to read us her narrative. I think it's very important. It will be interesting.
To read her mail?
Yes, yes.
I'm right. You want me to show it or to?
No, just read it, yes.
I'm writing you an email as the first thing in the morning before work, as later gets rather busy. So I took pyrogenium, as you said, around 9 o'clock because I noticed temperature was going up. I did not take paracetamol because I have told her to stop taking paracetamol to see till which high is going to be the temperature. I monitored the temperature, it continued to creep up, it reached 38.3. This was around half an hour after taking the first dose, and so it started basically playing up. It went down, back up, and it was going up and down, the temperature, till she stopped taking the temperature and she fell asleep. There was something strange. It's not important, but I want to share it. I remember dreaming about me feeling very good and telling a friend I was not ill anymore and being very happy for not having temperature anymore. It was so real that when I woke up at 3 o'clock a.m., I was not sure what it was really, a dream or reality. I woke up at 3 o'clock feeling my usual self. All symptoms I have had for the last days were gone, not there, nothing. I woke up my husband to tell him I could not believe, literally, no temperature, no nausea, no pain, just like that. And all this never came back, never had fever again or any of the rest. And
excellent, yes.
I hope this will end. And after that, the only symptom that she had, it was fatigue. Because I have to mention that she lost 5 kilograms all this time. She could not eat nothing, and she was drinking water because she knew that she has to drink water. She's a doctor. And that Friday, she became worse. She could not get up from the bed. She was sleepy all the day. And she had severe headache, pain, muscle pains, temperature, and she was in despair. And I could not reach her at the telephone, I could not reach her at the messenger, I could not reach her at all. So I decided to talk to her husband to see what is going on. I was very anxious because I didn't know what is going on. She had no other help from her hospital or something. She was at home. The good thing is that her husband is a doctor too, in a COVID clinic, so he was there to keep an eye on her.
I see. Well done. Very, very interesting case. And we thank you that you shared your experience with us. And at this point, let me show you again the Monarch inventory and the item 6 that we talked about the last webinar. And it says about the direction of cure. Did some symptoms improve in the opposite order of the development of symptoms of the disease? And here some practitioners answered yes, some no, and most of them not applicable. And we had a discussion. That's why Dimosenis told us today about the Hering's law and whether it applies on acute diseases or not. I think it is not very clear, my personal opinion, and I also had a short discussion with Professor Vithoulkas, and what he told me that is that this direction of cure observation is mostly more prominent in chronic diseases than acute diseases. But anyway, it is interesting to see that there are other views also as well. And nevertheless, it's good to discuss. I don't know, Dr. Chetna, if you want to comment on this. You have to unmute your microphone. Still, we cannot hear you.
Am I now audible?
Yes, yes, yes.
Okay. So first of all, I'll congratulate both the speakers on a very insightful presentation, particularly pertaining to the history of Hering's direction of cure and practical applicability as shown by Dr. Maria. So again, I'll refer to Dr. H.A. Roberts in his book, The Principle and Art of Cure by Homeopathy. He mentions that under a cure, the symptoms of a deranged vital function always disappear in the reverse order of their appearance. And this is true in acute as well as chronic disturbances. So that is one thing, that yes, it is applicable in both acute as well as in chronic disturbances. And another aspect is that in the present world, there is a paradigm shift in disease scenario. We witness many comorbidities, multiple drugging, changed lifestyles, environmental pollution, etc. So all this has led to more complex disease pattern where our therapeutic goal is efficient management, particularly for the chronic cases. So occurrence of cure is relatively less common, but it does happen depending on the vitality of the patient, nature of disease, etc. Therefore, when observed and reported, it strengthens the likelihood of the causality. So domains pertaining to direction of cure need further elaboration and validation. And I hope with the kind of inputs we got in this webinar, particularly the cases from Dr. Maria and our subsequent speaker, Dr. Tamara, we'll be able to gather more information and work on this further to elaborate and validate it. And another thing which particularly I like to comment on Dr. Maria's case is that during the initial presentation, this vital information was missing, how the complaints appeared. So it is very to inquire and report the has so that the physician case under the selected remedy. As she further interacted with the patient and she got these details, we can very well see that the symptoms they initiated with the fatigues, the sense of well-being, And the particular email which she read, where the doctor said that all symptoms, they disappeared quickly at the same time. There was no headache, no nausea, no fever. So we can say that, yes, it started with fatigue and other symptoms which developed gradually. They went on, they disappeared very, very quickly. And finally, only the fatigue was persistent. So based on the overall appearance and disappearance of the symptoms, we can say now with this complete information that yes, here this direction of cure is applicable. So my one request is that we should not base our observation on one or two symptoms, but we should follow the chronology of appearance and disappearance of symptoms when we comment upon direction of cure. Thank you.
Thank you very much, Dr. Chetna. Thank you again, Maria. Thank you again, Demosthenis. And now we go on with the program with Tamara's Romaine case, a very interesting, well-written case report that we have got. And I want to ask the attendees to have a look at the checklist that we have sent them with the newsletter. And after the presentation, we will make a poll to fill this checklist, the checklist of the guidelines, and then discuss on them. So, dear Tamara, thank you again for the time you invested in preparing and sending us this case. And we are anticipating now your presentation.
All right, thank you. Hello, everyone. I'm going to share my screen and get to the presentation. Okay, and there we go. Okay, so, oh, excuse me, hit the trigger too soon. This is a case report of suspected COVID-19 infected 32-year-old female veterinary technician treated with classical homeopathy. And I'm going to have to change my view here because I can't even see my own slide. If you can excuse me for a moment. There we go. Okay. And I'm Tamara Romaine. This slide presentation does follow along with the guidelines. So you will see at the top of these slides the number or the category that we are discussing. So the first thing are the keywords. This is COVID-19 suspected. Phosphorus is involved, classical homeopathy, and I do discuss the SARS coronavirus 2 test accuracy. The introduction of this is a suspected COVID-19 case in the United States with clear COVID-19 symptomatology, whose clinical picture improved dramatically after administration of the well-chosen homeopathic remedy. Without reliable diagnostic confirmation of a viral infection, principles of classical Hahnemannian homeopathy must be relied upon to find the simillimum by examining all the symptoms of each individualized homeopathy. The patient information and presenting concerns. This was a female patient, 32 years old, Caucasian, veterinary technician. She's the oldest of 3 children. She was adopted to a family friend at the age of 9. Her personal medical history. She claims to have no history of acute illness. She cannot remember the last time she did have an acute illness with high fever, but she did report a tonsillectomy and adenoidectomy at age 11. Recently in January 2020, she did have a LEAP procedure for cervical dysplasia due to the HPV. Her family medical, her birth mother was and is a drug addict. She has depression, has had depression, and cervical cancer. Her maternal grandmother died at the age of 72 years of cancer, both of lung and uterus. Her initial complaints as she came to me were intense, deep, dry cough. She said, unlike anything I've ever had in my life. Burning chest pain, burning sore throat. She had no congestion, just the dry cough, but she did have fatigue, breathlessness, and mild fever. Now the clinical findings. So she did have a diagnostic test, 2 of them. And the first one was given day 3 from onset. Unfortunately, the fluids leaked out of the test. This was on April 3rd, and so they never made it to the laboratory. This was discovered then by the 7th of April, when she, on the day 7 from onset, and this unfortunately is the day 5 after her first prescription, and that test was negative. And there is a high probability of a false negative for this. We are therefore suspecting still COVID-19 infection. And so to give you some background, during this period in the United States, there were not enough tests for COVID-19, and only patients whose symptoms were consistent with COVID-19 infection were allowed to be tested. The patient's primary care physician treated this result as a false negative, and the patient was quarantined at home as long as she continued to be symptomatic, or at least 14 days. The studies are revealing various reasons for false negative results, among them a short window of accuracy due to lower viral loads at certain stages of the infection, bad sample collection with the nasopharyngeal swabs, poor test quality, and poor lab conditions. These are just, this shows you the tests that were done. I have the documentation. It does say that she was symptomatic. This is the test that was given. It's the SARS coronavirus 2 RNA, the real-time PCR, RT-PCR test. This was given on the, on the 7th. That's the date that they received it, and the tests were documented on the 9th of April. So it does say in this, and this was part of the package that, or part of my what I submitted, that the negative test result does not rule out the possibility of COVID-19, and it should not be used as the sole basis for treatment or patient management decisions. And that obviously is true for those of us who are treating patients with homeopathy. Continuing with the clinical findings, she did have her fever measured at some point in the beginning. It was something that she just experienced, but the fever was measured at the primary care physician office and at home with oral digital thermometers. At onset of symptoms, her fever, as I said, was not measured. She had experienced a warm forehead, the checking, and chills. But after the symptoms worsened very rapidly, she did obtain a fever thermometer, and her first measurement was 100.2 Fahrenheit. Patient interventions, the primary care physician did provide her with an allopathic inhaler and other suppressive medicines. She fortunately did not use them. They were given to her because there was a great fear that she was rapidly deteriorating, and they were concerned about her. She did, without my knowledge, initially take, after I took the case, she used it twice for headache, and it suppression. Her fever during those days did go down and her appetite improved. So that was not helpful for us. The initial consultation was on day 3 after onset of symptoms. The rapid worsening of her symptoms frightened her, and she was very afraid of going to the hospital, more afraid of that. So that sort of encouraged her to come for homeopathic treatment, which she's never had. Now, continuing, I've included my initial case notes here. I've summarized them, but on the 1st of April, she did start feeling unwell. She began with a sore throat and a dry cough. And on April 3rd, that cough became much worse. She started having coughing fits. which frightened her a great deal. The coughing, as she said, was very deep. It felt she was having trouble breathing. She had intense or cold drinks. She had dry skin, dry mouth, which only aggravated her thirst. Her chest, with every cough, in the beginning, the chest was a burning pain that began with the coughing, and then by this time it became constant. She had a great deal of anxiety. She was very sensitive to noise, as she said. She was quite fatigued and did have fever, low fever though. The patient was referred to me by her employer. And so I have a comment here that at the time that I took the case, I was concerned about what was going on. There was a great fear in the United States at the point. I think everybody is aware that there was so much focus on the pandemic. So we were under a great deal of pressure. So I did use the VC acute, which I'll mention later, to do the analysis. Let me see if I can, as far as my findings, I will discuss this again later, but I did come up with the phosphorus as the correct remedy. I will explain that later. Unfortunately, I could not find the potency that I wanted to give her, which was the 200C. The only available at the time, and that was only in stores. Shipping was a problem at this time, as Dr. Peppa has explained in her case too. So I had to do something. I started with the 30C. We made a solution. I had her succuss, take it every hour. She would take a teaspoon, succuss before. Within 4 hours, she exclaimed that she felt so much better. She said, "Oh, my coughing fits are so much better." I would say 50% was when I asked her. She said 50%. But this did not last very long. Within 48 hours, then she had a relapse. So on the 5th of April, the above symptoms did return. This time, she had more head pain. Cough was deeper, was harder. She was having more fits. Then she would have vertigo, dizziness on coughing. She was having a great deal of trouble breathing. Moving about was difficult and would only increase that breathlessness. She had nausea as well from the coughing fits. Unbeknownst to me, she took ibuprofen for the headache on both of the days, 5th and 6th April. That did reduce her fever. So as we understand how that works. But so, and I did not know about this until the 7th of April. I had, during the 48-hour period before, told her to reduce the doses. Instead of taking it every hourly, I had her on every 4 hours because I saw that there was improvement. I thought, okay, this is good. But she relapsed, and so I had her then just take the remedy. I knew we were going to need to find the higher potency. So I just had her take that then with every fit, and she did reply, she did indicate that she would have improvement. It just would not hold. These clinical findings, I have a note here. There were keynotes of Arsenicum, Bryonia, Euportum, phosphorus, and all of these remedies have been indicated in cases of COVID-19. That was something we discussed in our previous webinars. Phosphorus was at the top of the list, actually, and all of them. And it was necessary to include the mentals in the analysis to solve for the simillimum. And so I will discuss that too. This is the initial repertorization. I did this with the acute analysis. We're limited to 15 symptoms. This is just a list of the symptoms. It just repeats what I've said. The coughing, I included, I used because it's the VC acute, you can choose a category, which I did, the influenza. That allows you also to see at a glance different remedies that are good for that. Obviously, I didn't know if we were dealing with influenza or the COVID-19, but they are similar. I took food and drinks, about her sleep, and I was I will continue here. Let me just say here that phosphorus did come out in this repertorization as being very clear. This shows you, again, these symptoms, and here I just opened up the phosphorus, and you can see that there was a hit on all 15. There was also some metadata here. Okay, so now after the relapse became evident, going on with this, I included some more, I did include some more symptoms. I did use the standard repertorization. We found that she had begun to have an aversion to sweets. She was desiring salt. She still had fever. She had head pain, and I told her not to take the ibuprofen and to use the cold compresses, and just to lay down with that. And it was remarkable because she did that and had a very fast response to that, which, as you will see, figures very strongly with phosphorus. So at the time, I did order the higher potency. The result of this new analysis, I retook the case. The phosphorus was still indicated. And again, the 30C did bring temporary improvement with after each coughing fit. So it just didn't hold. By April 9th, the phosphorus the 200C did arrive. It was wet that evening. She reported that she was feeling much better, and by the next morning she was remarkable. We did another follow-up on the 12th of April, and she said that really all of her symptoms were gone, except she still had fatigue, breathlessness, and coughing, but that she felt these things were about 75% better. She did, after taking the 200C, experience one long coughing fit, lasting longer than 15 minutes, and did take a dose of the 30C actually from the original solution bottle, and that helped a lot. And since that time had no more long coughing fits. That was what created the fear in her. I did want to say that what characterized her fear was that she thought something bad was going to happen. She said, what if, initially in the beginning, what if this isn't COVID? Then what is it? It could be cancer. Oh my God, I could have lung cancer. That was very striking with her. The other thing, as I was thinking of, well, let me continue. On the 3rd of May, she did report a full recovery with the exception of mild occasional cough. But I was beginning to see that some what might be new symptoms were beginning to emerge, perhaps old symptoms. I did identify one as an old symptom. And so I see that there is something has been uncovered through the treatment with this acute. This is the repertorization of the second time I retook the case. I had about 21. Let me go back. There were some changes here. Most of the symptoms were the same. But she did, where before she would sleep exclusively on her right side, she started sleeping some on her back. I started seeing these changes, which is why I wanted warm water would relieve some of her sore throat. So I was concerned, obviously. So I did retake the case with all of these new changes, and together with the old that remained, and it came out with phosphorus. Here are some others. This is in the case that you all have received, so I will just quickly go through. These again are still phosphorus, arsenicum, and bryony are still leading in there, but phosphorus is clearly indicated. This is something I wanted to show. This with the headache, putting the cold applications on her forehead was very strong amelioration for her. And so I felt very confident then with seeing this. So now we're asked to do a timeline. So before, in the previous, we've given our case notes. In this case, we're asked to do a timeline. And so I've just basically summarized things here, beginning with the 1st of April when she started to feel unwell and the symptoms, the onset of symptoms, to the 3rd of April, where the symptoms were worse. I received the case, I analyzed it, gave her the only available remedy I could. There was improvement. On the 4th of April, by this time, we reduced her hourly to every 4 hours. And by the 5th of April, her symptoms returned and actually seemed worse. At this time, she also took the ibuprofen, but by the 7th, when I discovered this, I retook the case, realized I was right, she needed a stronger potency, so we just had to wait for it. She stopped the ibuprofen. This is when I saw the advantage to the compress. This, with the headache, was very good that she took the compress to avoid. She was basically willing to stay with homeopathy. There were times when I was a little concerned that this was her first time, that she might, especially when the symptoms came back, might want to go to her allopathic medicines. But when the cold compress relieved her head pain, it really helped to settle her down. That was very clear. Again, here, severe coughing fits would be temporarily relieved by the only remedy we had, the potency we had at the time. On the 9th of April, she took her second prescription. On the 12th and 13th of April here, she has a strong amelioration from all of her symptoms except the 3 I mentioned. She began feeling well enough to work from home, and then returned to work at her clinic. In the state of Oregon, they were considered a essential business, but they had a great deal of restrictions, and because they were an essential business, the employees that were there needed to be protected. So she did need a clearance from her doctor, which she did receive on the 20th of April. And it was felt that she should take a couple extra days. So she did return to work on the 23rd. On the 3rd of May, I did another follow-up. And by that time, she was back to jogging, which I think is without any breathlessness, which I think is a very good indication. She still had occasional mild cough, but not with the same intensity, with burning pains or any of that. It's the first thing that came with the sore throat, and it is the last thing. Now, as far as the number 7, diagnostic focus and assessment, I did use the VithoulkasCompass for my analysis. I really like VithoulkasCompass. I don't think I will ever use anything else. The initial analysis, as I said, used the VC acute repertory, and it offers us a quick view at certain common remedies for certain disease categories. We are limited to 15 symptoms, which is in an acute situation, I think, quite useful. The keynote symptoms I mentioned here, I needed to definitely include the mental and emotional symptoms, because with the intense dry cough, burning pains, dry skin, intense thirst for big gulps of water, aggravation on motion, and then amelioration with resting. But I noticed with her that as she rested and settled down, she became restless. She did not want to stay still. And this is not bryonia. As I was comparing bryonia and phosphorus, I saw the dry skin, the dry mouth, the big thirst for big gulps of cold water, motion aggravated, but she desired company. She did not want to be left alone. She was not grouchy. She was rather friendly and sympathetic, which contributed, and that was in my repertorization. So I ruled out the bryonia. Regarding phosphorus and arsenicum, she desired company, though. Both of them do, but for different reasons. It was with the arsenicum, I see burning pains, chilly, but the cases of the company and the thirst, she was going for big gulps of water, not frequent small sips. And her reason for company was that she wanted to interact with her housemate. She was not looking for reassurance, as is often with arsenicum. The therapeutic intervention, strict individualized classical Hahnemannian homeopathy. Also, in addition, some common sense measures: resting, no coffee. We found that the warm honey and lemon water helped to soothe her throat. Asked her to please stay away from ibuprofen, which she did eventually. Cold compress for head pain, as I said, was very significant. And stay away from her allopathic inhalers and suppressants. The remedy, we need to say what the remedy is that we used. It was boron, 30 CH, and also the 200 CH pellets. They were both purchased from the local health food store. If I'd had the luxury of purchasing elsewhere, I would have gone to one of our labs, like Hahnemann Lab, but we didn't have that. We had to go with this. And we did, the 30C was dissolved in a bottle with water and alcohol, vodka for preservation, and succussed, and then each dose was 1 teaspoon succussed approximately 5 times before, succussed 5 times before each dose. Now, follow-up and outcomes. I pretty much have followed this. 4 hours after initial dose, patient texted, "I feel much better." She was very enthusiastic. Let me see, I have to move I cannot see the rest of my slide here. So the coughing was not as bad. That was better, she said. She did sleep very well that night, where she hadn't been. Vertigo and nausea was not triggered. She felt no fever. Then again, 48 hours after initial dose, she did have the full relapse. We indicated that the 30C relieved but didn't hold. The patient did not report this to me until another 2 days had passed, at which time, as I said before, I retook the case. Remedy was unchanged, but I did confirm that she did need the higher potency. I would have started with that in the beginning if I had it. Continued to use 30C in the meantime. Overall, she was basically during that time unchanged. 2 hours after taking her dose at higher potency, there was significant improvement and the effect did hold. The follow-up 1 month later did show that only the slight occasional cough remained. And again, as I said, new symptoms seem to be appearing, which could be old symptoms from a time prior to this acute. Return of an old symptom after beginning homeopathic treatment. This was specifically, in her case, leg cramps during sleep. There were no leg cramps prior to taking the remedy. She had the leg cramps some year or so before that bothered her for a while. I, in the moment, don't remember exactly what she did. Some suppression measure, but at the point when she started becoming ill, she did not have them. The leg cramps did return after treatment started, and I will continue to follow this patient. Discussion. Discussing this in terms of the MONARCH inventory. This is a very useful tool for evaluating chronic cases, and it appears to be useful for acute cases, such as this case. There was a clear improvement in the condition of the patient because of the homeopathic prescription within a plausible time frame. Overall well-being improved, and the direction of cure was towards health. The mental emotional symptoms were relieved, and the first symptoms to appear, the cough and sore throat, were the last to improve. The mental emotional symptoms did relieve first. At least one old symptom did appear during treatment, the leg cramps during sleep. And as I said, she had not experienced that in a very long time. I did do the MONARCH inventory while I was doing this case after I became aware of this, and I found it very, very helpful. So we'll continue. We have to, in the interest of time. The discussion should also include limitations and strengths. The limitations in this case were the lack of positive test result, unfortunately. Also difficulty in obtaining remedies or the needed potencies. I was beginning homeopathic care for this patient during an acute instead of a chronic condition, which would have helped me had I been able to start treating her first. I would have known more about her, and I could have had a bigger picture view of this. The strengths of this quite clear and consistent with strong patient remedy with the patient having a positive experience and her sense of well-being improved. Patient now understands her personal medical history better, and she wants to continue treatment for what she sees now as a chronic condition. And the takeaway here is that homeopathy for COVID-19 and other infections should be individualized. So learning points are covered. Again, homeopathy for COVID-19 should be individualized, like all cases of illness. Levels of health and comorbidity should be considered in potency selection and analysis. I do find my patient to be sensitive. Tests for COVID-19 have a high rate of inaccuracy. So we must consider all the symptoms and not rely solely on tests for finding the simillimum. This acute illness, like COVID-19, is not an isolated event. It is part of a process of healing by the vital force, either initiated by us during chronic treatment, we cause it to happen, or in this case, I see it as spontaneous in the course of her life. She's a young person, she still has vitality. A successful treatment of an acute illness can uncover an underlying layer, and I'm thinking in terms of Professor Vithoulkas's continuum of a unified theory of disease. I think this is very applicable here. The patient perspective, she was very happy to provide us with a narrative of her experience. And so on the 7th of May, she did send me an email. This was my first experience with homeopathic care and treatment. From the beginning, I really enjoyed how myself, as a whole person, who I am now and what my past has been, was considered and what was best for me. There was a different level of care presented. You were being asked to have input in decisions for your own health. Each day I was checked in on and my treatments were adjusted. There wasn't a prescription given for a certain amount of days and you were forgotten. I learned a lot about myself and what it was lacking and needed to help itself get over my illness. Through my treatments and evaluations, everything was explained to me with such care, and it all made sense as to why I was doing and taking what was recommended. I don't think I would have recovered from my illness as fast and with little inconvenience as I did without homeopathic care. It has changed my view on medicine and how my body needs to overcome health obstacles. So this is very positive. And thank you very much.
Thank you very much, Tamara, for this excellent presentation. You did the repertorization, which was excellent, the differential diagnosis, and I think it is very also learning for us that you followed all the procedure of the template that we have, that Robert prepared according to the home care guidelines. And now we have some questions about your case, but first let us complete the poll. Andreas will send all the attendees the poll, some questions about this case, and we will further discuss the case and along with the questions that we have from the audience. Now you see on your screen the checklist. And please write the answer that you think that it applies to the case. You will have 3 polls of 10 questions each.
Just to compliment you, that the information about the abstract, which would have been in the home case care checklist, does not apply in this case, because that's more when it's published in a journal.
Correct. So, do you want me to read also the questions briefly? The first one is that if the words case reports are in the title of this case report. This is question 1. Question 2, does this report has 2 to 5 keywords? Question 3, does this case report has introduction with brief background summary of this case, referencing the relevant medical literature. Question 4. Does this case report include demographic information of the patient, such as age, gender, ethnicity, occupation? Question 5. Does this case report contain the main symptoms of the patient, his or her chief complaints? Question 6. Does this case report and relevant genetic information? Question 7. Does it include relevant past interventions and their outcomes? 8. Does it include the relevant physical examination findings? 9. Does it include clinical history detail, i.e. homeopathic symptoms used for decision? And 10. Does it chronologically depict important milestones related to your diagnosis and interventions? Let us say again that these are guidelines that show us what should be a proper case report in homeopathy. Robert, do you want to comment further on this?
Just to clarify for the attendants, is that the actual home case care checklist has a little bit more than 30 items, but for the purpose of this webinar, we had to slice it in 3 polls of 10 questions because the video conferencing system limits us to 10 questions. So the idea is now that in the coming minute or so, we're going to close this poll and then we will discuss, we'll have a look at some of the answers. We will see if there's any questions and answers or comments regarding these. And then we will move on to the second batch of 10 questions and then followed by the third batch. So after each batch of 10, we will have some discussion, but focused on these 10 items. If the discussion points concern points further down, then we will postpone that discussion until a little later.
Okay, while we wait, Chetna, we have a question for you. You have a fan that says, Dr. Chetna, can I have your contact, please? And where are you stationed?
So I'm stationed in New Delhi, India, and my email ID is drchetnalamba@gmail.com. I'll just type it.
Thank you.
All right, I think we're gonna have to close the poll fairly soon now.
Okay. Andrea, do we have some answers? Mm-hmm. Can you see the answers, Robert?
Yeah, I can see them.
Okay.
So I think these two are quite straightforward. There's a very high level of consensus here. So let's move to the next question.
So question 1 is about the title, if the title is proper with the words case report, and question 2 about the keywords that the case had. Okay. 3 is about the introduction. You are muted.
Can it be scrolled up? Because I'm not sure that we can scroll the results.
You can.
You can, Robert. You can do it by yourself. If I do it, you will not see the rest of the answers.
Okay, I don't seem to be able to scroll it. I don't have a bar. So if
the question 3 is about the introduction. Does this case has introduction? And we have 71% answered yes, 21 no, and 8% not applicable. So what do you say about this?
yes, so I had, in terms of, I understand why there is slightly higher percentage of no, because, for instance, something that would be missing is in the state of Oregon when the patient was included in the study, how was the COVID epidemic evolving, so that would be relevant background information. And so ideally references should be given about, okay, it is relevant because there is some unclarity about the diagnosis. It's relevant to know, were there a lot of cases in the state of Oregon? Was the epidemic on the rise or going down? So I actually was one of the people who indicated no as well. It's not that it was completely lacking, but it could be a little bit more granular and complete to give us that a little bit more context.
Okay, then we have question 4 about the demographic information of the patient.
Okay, I think
okay. Then we have 5 about the main of the patient and everything as well. Question 6. Does the case report include medical, family, and psychosocial history, including comorbidities and relevant genetic information?
Yeah, I think it's a fair amount of agreement that it was included. But just bear in mind, it doesn't necessarily mean that absolutely everything needs to be covered. So in this case, genetic information wasn't necessarily relevant. So it's not that because there are 3 or 4 or 5 items mentioned here that if one of them is missing, that it automatically becomes a no, because maybe that has been sort of the perception of the 8% that indicated no.
Okay, 7. Does it include relevant past interventions and their outcome?
Yeah, I think that there is a little bit less clarity on that. I mean, there is, I think it's understandable that there is some perception that some detail may be lacking, because there is some references of the ibuprofen, but it's not exactly clear in a more systematic way what happened. I think the case does address it, but I think there might be a perception, a partly justified perception that you know, that it wasn't, didn't necessarily have the granularity. I don't know, Lefteris, what you answered on that one, or if anybody of the 19%, because 19% I would say is a slightly higher percentage. So we will check the questions and answers yeah, if someone feels very strongly about the no, they can mention that as a comment, and we can then pick up on that in the discussion.
Tamara asked if I understood well, the patient was taking homeopathy for the first time in her life.
Yes.
Yes, I think you said it. Now
Yes.
about other interventions, about other medications, I don't know if you have this information.
You mean as far as what else she might have been taking before?
Yes, but here, Robert, I think we are talking, aren't we talking mainly about the acute event of the COVID infection? So I think since she was taking only ibuprofen or something, so I think this is reported in the case. So I think we can also answer yes in this item as well.
Yes. No, I feel it's justified the yes as well.
Yes.
And but it's important to have this context that these past interventions refer to this disease episode. And so in this case, the main reason for visiting, seeking the treatment was the suspected COVID. So it should be seen in that context. And I agree in that sense, there is a yes.
Okay. 8, does it include relevant physical examination findings? We have yes 58, no 31, not applicable 12. Physical examination findings.
I indicated not applicable, but maybe I can be proven wrong. I thought this was a consultation via video link.
By phone. By phone.
Yeah, or by phone. It's not exactly clear to me that a relatively high percentage said yes. Maybe I missed something in the detail of the case here. Can you comment on that, Tamara?
Perhaps because she had gone to her primary care physician who examined her.
Yeah, that's why I also put yes on this, because she was examined by a doctor. That's what I understood. Yes.
Yes.
But we don't know what was done.
Not much, but that's true. I could have included that. They took her temperature, looked in her mouth, said was very concerned about her, said go take a test. I mean, there was very little done. There was not much. And in that I probably should have stated that at the time, it was encouraged for patients not to go to their doctors. It was encouraged for them not to go. So she would have had, anyway, a limited examination. They wouldn't have gone very far.
Yeah, but in this case, it's quite interesting because you could argue it's not applicable because it was a phone conversation, but obviously there was reference to that this person was visited their physician. But for this to be a true yes, the idea is that the case report contains that detail. So in a way, it doesn't really matter in this case whether this physical examination was done by you or by someone else, but the reader should be able to say, okay, what was done? And so in a way, in this case, it was done, but we didn't need that granularity. What was done by the primary care physician, and what was the finding there?
We see. Okay, 9, question 9, does it include clinical history detail, i.e. homeopathic symptoms used for decision? We have 88% yes on this.
Okay, I think that's a fairly high level of agreement.
Yes. And the last questions of the first batch, does it chronologically depict important milestones related to your diagnosis and interventions? Milestones, I think we had also this. What do you think, Robert? We had the timeline.
I think the timeline was sufficient, adequate. Yeah, it might be that some people felt that certain important aspects were missing. So again, if from the 12% that said no, it would be interesting for them to join this discussion and say, well, what from their perspective was missing? Because we should be open for the fact that we might have missed something that is relevant.
Mhm.
Great. Okay, now we go on to the second batch. Andrea, please send us the second 10 questions. I think this is very educational for every one of us to see in practical, to apply and to think over a real case and to learn about these guidelines which we omit in many of our case reports.
Second. Okay, I've got a problem with it.
Okay.
Okay, well, all good
Okay,
to go.
this is the poll 2. Eirini, can you help me on this? Can you read the questions in order for the attendees to hear them?
Okay.
Thank you.
Can you hear me?
Yes, very well.
Okay. So the first question, does it include diagnostic methods such as physical examination, laboratory testing, imaging, questionnaires? The second question, does it include diagnostic reasoning, including other diagnoses? Third question, does it include prognostic characteristics in relation to the conventional diagnosis? Fourth question, does it describe the type or types or interventions such as pharmacologic, surgical, preventive, self-care? Fifth question, does it describe the type of homeopathy applied, individualized or formula, single or multi-constituents or isopathy? Sixth question, are the medications well described? Nomenclature, list individual prescriptions or constituents, plus trade names, manufacturer, potency, scale, and galenic form? Seventh question, is the administration or of intervention such as dosage, strength, duration described? Eighth question, are any changes in intervention with rationale described? Ninth question, are clinician and patient assessed outcomes described? And the last question, does the case report include important follow-up test results?
Very good. I have answered mine, so let's wait for the attendees. A question, Tamara, that we have is, are you planning to do an antibody testing?
Yes, we're trying to get an antibody test. Again, these things are very limited right now, and it's very widespread disagreement on the accuracy of them too.
Yes. But
yes,
in any way, it's good to do it. Yes,
yes,
to
yes.
have it.
Yes, the patient already is on the list, on the waiting list to get an antibody test. Yes, I definitely want it.
It's a pity that the first test was destroyed because
Plus,
yes.
I wish you could have seen. I was thinking to myself on the phone as I took this case, oh, this is great. It's going to be, the test will be before the remedy is taken. It's, you know, so many days after symptom onset. I was so pleased. I had to hide some of my joy, but it was the relief. And I was so disappointed when they came back and said, I was expecting the test result, and she came back and said it was damaged. It's just heartbreaking. And we'd already been treating her now for several days.
I mean, this is why in the care guideline, there's also references to diagnostic challenges.
Yes.
And that's something in this case, because many people often say, well, what do you mean with diagnostic challenges? And it says, such as financial, language, or cultural. And this is a very, very specific case where you were facing very particular diagnostic challenges. So this is very, in your case, actually, in your ultimately published case report, that would need to be addressed.
Doing like screening here in Crete for some people that they were very, how to say in English now, I'm suspecting that they have passed COVID, but they're all negative.
Yeah.
I don't think that these tests here are good. For example, it was a woman that she went to England. After that, she went to Constantinople. After that, she came back here. She had fever, pain in the chest, cough. Her physician examined her and he said that she has the, I don't know how to say, πώς λέγονται τα κουραστικά.
The findings from the
were very, yes, the findings
her
from the
lungs
observations were much worse than what she was feeling, and the test was negative.
I see.
Every test here is becoming negative. For IgG, I'm telling. And she,
the antibody test, yes.
yes, and she didn't took homeopathic remedies. I just advise her to do it as a screening, and I have done 5, 6 till now. Everything is negative.
All right, okay, so let's move on. Let's go through these results. So,
okay, do you want to comment on them, Robert?
Okay, yeah. Yes, I think it does include diagnostic methods. It's a clear yes for me. There's no, the fact that there were some challenges, that doesn't mean that the diagnostic methods were there and a test took place. So I think there may be some impression that it should be no because it was not clear, but the care guideline is a checklist to see, okay, was something addressed? And if something that was addressed is a bit ambiguous or unclear, that doesn't mean that the item is negative. It's really whether it's about transparency in the reporting of case reports. And this transparency is there. But of course, the transparency is that, yeah, there were some challenges.
Yes, and we have a relevant question about this, whether this case may be a pneumonia or a seasonal flu. And because the questionnaire, the question attendee writes, because we have many critics on homeopathy. And because the patient has not come in contact with a COVID-19 positive patient. But to my understanding, I think it is. We can say we definitely can say that it is a suspected COVID-19 case, because we also received, as VithoulkasCompass, other cases, positive cases, but we picked Tamara's case because it is very well documented. So that's the reason. Yes.
But,
so
there is validity in the no's, the 25 no's, if we move to question 2, in the sense that the case could more explicitly address the differential diagnosis from a conventional point of view, because it was, from a conventional point of view, the diagnosis was unclear, and something could have been said about the fact that, for instance, okay, what's happening in terms of the number of cases in Oregon? To which extent did the conventional doctor again did a clear differential diagnosis, whether there could have been other reasons for pneumonia, other reasons. So I think it is about this transparency, about the diagnostic reasoning. And so this case, I think, is lacking some of that transparency. So I do feel that that it can be slightly improved at that level, and I think that's also picked up by at least a number of the responses. Now, prognostic characteristics. I think that is quite of a mixed thing, I guess. The prognostic characteristics is more when, for instance, there's a cancer patient and that there is something about the stage of the cancer. So strictly speaking, if we look at the origins of the care guideline, this does not really apply, I would say, not applicable. But we can see here there is some confusion around it. But from a conventional point of view, it doesn't really applicable because there is, in the first place, not even a very clear diagnosis. And then, even if there were to be a confirmed COVID, I don't think the prognostic assessment of this case was explicitly addressed. So then if we move to number 4, the types of interventions, I think this case, personally, it's a clear yes. Even the fact that, not in the initial report I'd seen, but in the PowerPoint presentation, that something was mentioned about what was the advice given to the patient in terms of self-medication or take lemon tea. All this information is or could potentially be relevant. And so, again, the characteristics of a really good case is where the reader can build his own opinion in a way. And sometimes people can agree on the interpretation, but a good case report enables the reader to form his or her own opinion. And so if nothing is mentioned about self-care, you just lack a little bit of information because you thought, well, maybe they were taking VapoRub or maybe, and in this case, that was in the PowerPoint very well addressed, that this was the type of self-care was made transparent. Type of homeopathy, that's an easy one. We had a full agreement on that. Medications, I think overall, yes, they were very well described. The posology was addressed. The manufacturer was addressed. So I think that was, generally speaking, agreement. How the administration, when there was changes in the dosing, full marks for this case report, because it was very clearly described, okay, initially there was a higher dosage, when and how the dosage regimen was changed. Any changes in intervention, again, I think we were very well addressed in this case. does the case report important for results? I think, yeah, that there is kind of, I think there is sort of unclarity in the sense that which test, and ideally, yeah, you would have wanted to see maybe what about the test, what about the COVID diagnosis, and I think this mixed response reflects that there is some unclarity about. So I think the honest answer should be no, because there's simply slightly a lack of clarity about how that follow-up was done.
I answered no. I answered no. There is a Denny. If I may comment quickly, and I should have addressed this. We wanted a follow-up test, and they weren't. She can't have one. Because of the scarcity of tests. And at this point now, we're just hoping for the antibody test. But yes, it would be good to have that, and we are really wanting to have that. But I could have addressed that.
All right, thanks. All right, so let's move to the third poll. We're running a bit short of time, so we're going to accelerate a little bit. So let's get cracking on number 3.
Okay, Eirini, can you again read it? You read much better than me.
Okay. So, first question. Is intervention adherence and tolerability described? Second question. Does the case report include adverse and unanticipated events? Third question. Does the case report include objective evidence? Fourth question, I think there is a small mistake. Does it describe if there is a homeopathic aggravation? Fifth question. Is the possible causal attribution of changes explicitly assessed or discussed? Sixth question. Does it include a discussion of the strengths and limitations in the management of this case? Seventh question. Does it discuss relevant medical literature? Eighth question. Does it include a rationale for the conclusions, including assessment of possible causes? Ninth question. Does it include main takeaway lessons? Last question. Does it include the patient's perspective or experience?
Very good. This is the last group of questions. There is a reason to make another prescription for the slight coughing fits still remaining to your patient. As we see in Brazil as well, some symptoms remain for quite a long time after COVID-19, treated or not treated with homeopathy. This disease seems to take at least a month or sometimes even 2 to be totally free of symptoms.
Yes, as a matter of fact, I'm still following the patient. And at the time I did the analysis on the 3rd of May, I did not see enough clear changes to warrant a new prescription. So I just held it, just didn't interfere. I didn't see a reason, because she was continually getting better. Even though the cough was present, she was still getting better, and I didn't feel repeating was a good thing to do at the time. Since then, we've had another follow-up. I'm following her now weekly, and I am now seeing significant changes, and a new prescription has emerged, which it's not in the scope of this right now, but yes, it is. And there has been from this new prescription, interestingly enough, even more improvement regarding that cough. But some of the new symptoms that came up, she had very clear new symptoms come up in the last couple of weeks.
Very good.
That's a very interesting feature but confirms what Robert said, and I think Hahnemann as well. So that's really nice to see that. I think it's a very nice feature.
Yes.
Right, I'm looking at the clock, so I'm going to have to accelerate a little bit. Let's go to the results of the Andreas, to the 3rd poll. In some ways, now we're waiting. I thought it might be because you gave phosphorus, which can be also it's a constitutional remedy as well. It seems to me that because as you point out yourself, there's this deeper layer and then there's acute disease, which is not totally independent of these deeper layers.
Correct.
It seems that phosphorus has touched also a bit, whilst it was the acute similimum, it's bringing out some of these deeper layers.
Yes.
Which is fascinating, because I think this is really what I think Herring and Hahnemann were trying to get at. Unfortunately, there was a lot of confusion created by this being called a law and things like that. But the principles they refer to, I think, are very valid and useful.
Yes.
And we still see them.
Very much.
Andreas, can we have the results?
Okay.
Okay, right. So yes, intervention adherence, generally speaking, yes. I answered yes. Some people still feel that there was a no. Maybe the people who said no could make a comment on that, so that we may be able to address that. So I'm going to move on for that. Does the case report include adverse and anticipated events? This is interesting because there seems to be a bit of a mixed reaction here, and I think I understand why. Because technically speaking, it's important to report that, to make explicit that there were no adverse or anticipated events in relation to the medicine. I mean, if you really look at the conventional definition, is that even if it doesn't occur, it should be briefly mentioned. And this is again transparency. I think the fact that there's some lack of transparency here has triggered 40% to say, well, no, it's not clear, so it's a no. Objective evidence, 73%. There seems to be a fairly higher percentage of no. I think it's objective evidence towards the outcome. I think maybe there's some confusion around that there. Lefteris, what's your feeling about this?
Objective evidence. I think that temperature is objective evidence. The test is objective evidence. So I answered yes.
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 I mean, in general, we are propagating a fairly inclusive definition of objective. So it's not just only a lab test. if the temperature is taken, that is objective. And sometimes if there's some sort of, then also rate that as objective in the sense that it's an observation by some sort of external observer. So yes, in this case, I agree, it should be yes. Does it describe if a homeopathic aggravation occurred? No, yes, I had no as well there. The general feeling is it didn't occur, but again, transparency. If something doesn't occur, the author should make that explicit, because otherwise there is still this nagging doubt that maybe there was an aggravation, but it wasn't mentioned. The fact that someone says there was no homeopathic aggravation means that the prescriber has explicitly thought about this and explicitly said, no, it didn't occur. And in this case, we feel it's probably not. And so that's why quite a few people still said yes, but actually it is not transparently described. So I think the 60% got that right. Is possible causal attribution of changes explicitly assessed, discussed? For me, this is a resounding no. If all cases, if all cases would describe the MONARCH and make transparent how they've rated the MONARCH items, this is really the ideal situation that we would like to see, because you can follow the reasoning why someone says, I'm confident that this is the attribution, the causal attribution is there. So I'm not very clear about the 24% that said no. So if anybody wants to make a comment on that, they can. Strengths and limitations, yes, 78%. I agree, yes. It's a very important aspect, and most case reports that we see tend not to do it. And I told in my earlier webinar that a case report is in a way a scientific study, and the architecture of a case report is completely similar to what you would do in a scientific paper, in a randomized controlled trial, in an observational study. And so it's important to recognize the limitations, to be self-critical. And this is really what is lacking. And this is also one of the reasons why I tend to put so much emphasis on this critical thinking. Think about your biases. Think why you may have been drawing a wrong conclusion. Because if you address that, that gives the reader the confidence that you really detailed discussion on what's COVID, what's the evolution of COVID, this case resolved within a certain amount of days. What does the literature say about that? Patient with that type of severity, on average, how long does it last? These are the kind of things that if you publish, and we will be publishing this case because it's an excellent case overall, that would need to be more explicitly addressed in the discussion. And rationale for conclusions, I think, yeah, that's fair. That was overall made explicit. Main takeaway lessons, very well done. I agree with the 84%. And this patient perspective, it's so nice to see these patient perspectives, because it's the narrative of the patient is ultimately what motivates us, what moves us. And to see this direct narrative of the patient can be extremely powerful in terms of connecting us that, yeah, this is a real patient with their hopes and their fears. and it's optional in the care guidelines. It says include whenever possible, but it's a very valuable thing. So I think that's where I have to leave it. We're running out of time. So I think if there are discussion points, please put them, write them, make the comments, and we will still follow up on some pertinent questions. And obviously we will debrief you after this event is finished. And some of the lessons or points that you may want to raise where we had no time, we will try to address also when we give you the sort of the feedback and the debriefing after this webinar. But I'm going to hand over to Lefteris.
Thank you very much, Robert. Now we go on quickly to the ceremony, the VithoulkasCompass Award ceremony. First of all, I want to thank every participant that attended this webinar series. The response surpassed our expectations. We had many participants, and thank you for this. Also, I want to thank every practitioner who has sent us cases through VithoulkasCompass. Especially, I want to thank Dr. Vineet Sindarthan, who has sent quite a good number of cases. Dr. Vineet and Dr. Shelly Sharma were the winners of last year's contest that took place in Sorrento during the LMHI conference in Italy. Because well-documented cases and especially and in general case reports are important because they contribute to collecting evidence about the efficacy of homeopathy. They help us sharing the experience, and last but not least, the statistical data derived from these cases help us to improve the repertory, the materia medica, and the expert system, as Professor Lilas explained us in the previous webinar, how we use this in VithoulkasCompass, these cured cases, in order to improve not only the repertory and the materia medica, but the actual expert system, to improve it and to calibrate it to find the specific parameters, how I mean this parameter in relation with the other, and finally to have an overall weighted brain, let's say, expert system to help us find the remedy. Now, if we were in a conference room, I would now handle you the awards, and I would even kiss you if we had not the pandemic. But let me show you at least the awards, and we will send you also through email and through normal mail, through post. Okay, let me share my screen. Okay, this is Tamara's certificate. You see my screen, Tamara, eh?
Yes, I do. Thank you.
This is to certify that Tamara Romaine participated in the collection of high-quality COVID-19 clinical case reports organized by VithoulkasCompass. The submitted case excelled as a high-quality case. Okay, and this is the certificate for Maria. This is to certify that Dr. Maria Peppa participated in the collection of high-quality COVID-19 clinical case reports organized by VithoulkasCompass, and the submitted case excelled as high-quality case. Thank you very much again. This whole webinar series was the educational even for me. I want to thank again Robert, to thank Chetna, and all of you that contributed in this webinar series. And now I would ask Eirini to as a representative of the younger generation to tell us something about homeopathy in general and whatever she wants.
Hello from me again. I really hope that...
Excuse me, Eirini, I forgot the most important thing. Not only the certificate we have for the winners, but we also have 1 year full subscription, full year account, 1 full year account in VithoulkasCompass. Unlimited subscription for 1 year. Excuse me, so please.
Okay. So I do hope that we have all been greatly benefited from this series of webinars. And we're very honored to have acknowledged members of the field of homeopathic research sharing their knowledge, wisdom, and guidance, as well as homeopathic doctors dedicating their time to provide us with their experiences. So for me, as a younger member of the homeopathic community, I feel it was very educational and inspiring. As this webinar comes to an end, I would like to humbly share some thoughts. And I would like to report from my small experience in the homeopathic community that I have encountered a lot of skepticism, especially from young fellow scientists and health practitioners. And this is quite strange because usually the younger generation is more welcoming and embraces more easily some more the new ideas and the more holistic point of views. And usually they share strong doubts about the efficacy of homeopathy. And this makes me wonder what will the future be for this therapeutic method, especially in the Western world, where there are countries where homeopathy seems to be slowly losing its initial glow. So for my part, as a thought of closure, I'd kindly want to motivate the older and most importantly, the younger generation of homeopaths to engage their practice and case reporting in scientific principles, critical thinking, and methodology, as they were discussed in this series of webinars. We are very thankful for the fact that compared to the past, now we have the knowledge and the guidance on how to apply this critical thinking methodology when analyzing and reporting our cases. And we should bear in mind that these are the sole means that could defend homeopathy against any skepticism when this therapeutic methodology is put to the test. I dare say on behalf of the whole panel that our hope is that more and more members of this wonderful community contribute to the defense as this humanity is kneeling in front of a pandemic in the absence of any conventional treatment to battle it. For this reason, every single case counts. We wish you all great successes, beautiful results towards the direction of cure, and please let the world know about them. And VithoulkasCompass software is dedicated to this for this reason and this purpose. Thank you very much.
Thank you very much, Eirini. And thank you again, everyone. Thank you, Demostheni, for being with us today. It is our honor to have the president with us.
The honor is mine.
Thank you, Dr. Chetna, again, for your support in all these webinars. Thank you, Maria. Thank you again, Tamara. Thank you, Robert. Thank you, Theodore, my colleague in VithoulkasCompass. And so this first webinar series, we hope that we continue it. We'll see after summer, perhaps we could organize something new. Now, regarding your questions, we'll try to type the answers. And if you have further questions, please email us at at VithoulkasCompass.com or at info@VithoulkasCompass.com. Andreas will receive the emails and will answer. Of course, we thank Andreas for the wonderful host in all these webinars and for solving every problem that was coming up. Theodore, yes?
Okay, I would also like to thank all of our participants, and we will continue to receive cases and also provide some benefits for the homeopaths that submit cases. And so we will also in a few months present results of the analysis of COVID cases. And also this collection of cases will not focus only on COVID cases, but also on suspected COVID cases and acute cases. So your support is really useful for providing evidence regarding homeopathic treatment and also improving VithoulkasCompass homeopathic software that supports homeopaths. So thank you all.
Okay, thank you very much. I wish you a nice summer ahead.
Lefteris, can I just make one final comment? Again, I think is just 1 minute to give my perspective. Having started many years ago on this topic of improving case reports is really great and encouraging to see that globally the homeopathic community is engaging in this process so proactively. And I think this webinar and the interest in this webinar underlines that this interest is there. And I see this really as a process for homeopaths to get more in that frame of becoming more and more rigorous in the way they approach it. And I mean, I mentioned in the first webinar that our brains are hardwired to see causality when there is none. And conventional medicine has sort of, this has led conventional medicine the likelihood of biases to say, well, case reports, that's anecdotal and biased. And I think that is now being perceived as a wrong approach. But of course, it is very important to apply this critical thinking and to be aware of these biases in terms of towards clinical case reports. And I just want to leave you with this metaphor of that the home case care guideline and the MONARCH, it's a bit like a lens. I mean, if we don't have a sharp lens, then everything will look a bit unclear. And so the MONARCH and the home case care guideline enable that granularity in the case report, enable that clarity in the case report, that you feel that you can have a more in-depth discussion. But if you can't see clearly, your ability to learn from your cases is far less. I mean, I have personally learned that the importance of this towards cure why are we able to do and granularity in the case report? So just consider this a bit like we're having just better glasses, a better lens to learn more individually. And obviously, if our individual cases get better, then our case series, the collection of our cases, get better. So finally, when I teach these programs about critical thinking, then often I mention this thing about doubt and positive doubt. And quite often people say, you know, we're starting to apply this and I feel a bit less confident as a homeopath than before. And I always say that's a good sign if you don't have a certain the fact that you feel a certain level of discomfort means that you become a critical thinker. It means that you start questioning yourself. Now, the problem with human psychology is that if we feel discomfort, we'd rather avoid that. And so that's why confirmation bias and all these biases are so common, because we prefer to keep that sense of cognitive ease. And so we just block that. But unfortunately, that prevents us from learning. And so just the last thing I want to leave you with is that we need to learn to, I always say, how can you overcome that sense of discomfort? I always say, but we should foster that sense of wonder, a bit like a child, that you're in the world, there's so much interesting stuff to discover in this world, there's so much to learn. And so in a way, if we foster that curiosity, we do have this ability to learn, and we should keep that ability to learn. And that's really what I wanted to leave you with. And thank you very much for participating in this experience. And we hope that we continue on this journey.
Thank you very much, Robert. And what we want to do is not to claim that homeopathy cures or prevents COVID-19, but we want to learn, as you said, we want to investigate the potentials and the limitations of homeopathy by collecting cases and studying them like real scientists. Okay, thank you very much again, and see you soon. Bye-bye.